Good evening, everyone. My name is Gissette Soffer. I'm an associate professor of medicine at Columbia University Medical Center, and it is a great pleasure to have this webinar tonight, which will be given by Dr. Mintz. Dr. Mintz is an associate professor of medicine at the Zucker School of Medicine, as well as a fellow of the American College of Cardiology, the American College of Physicians, and the American College of Chest Physicians, the NLA, and the American Society of Preventive Cardiology. He is the co-director of the Lipid Center for Northwell Health System. He's on the National Executive Board of the Directors of the National Lipid Association and currently serves as the president of the Northeast Lipid Association. Dr. Mintz has received many awards for clinical teaching and currently is a preceptor for the Advanced Clinical Experience Program at the Zucker School of Medicine and has additional roles at the St. John's University Physician's Assistance Program. After starting his own cardiovascular practice in the 80s, in 2017, he decided to take on a new challenge by joining the Sandra Atlas Bass Heart Hospital at Northwell Health System as Director of Cardiovascular Health and Lipidology. And currently, he's Director of the Lipid Apheresis Program, which is very relevant to the program that we will have here today. I would just like to mention that we're honored to have you, Dr. Mintz. Thanks so much for this presentation that you will give us. And Opus Medicus designates the score for a maximum of 1 MA PRA Category 1 credits and ABIM MOC points. Physicians should claim only the credit commensurate with the extent of their participation in this activity, and the guidelines for how you will get that credit will appear in the last slide after we finish our discussions. So without further ado, welcome Dr. Mintz, and we look forward to your presentation tonight.
Thank you, Dr. Soffer, for that wonderful introduction. Tonight, we're going to focus on lipoprotein A as an independent risk factor for cardiovascular disease. And I just want everyone to appreciate the fact that atherosclerosis is a diffuse disease that affects all vascular beds, and certainly LPA is a modifier and a cause of progression of atherosclerosis in these various patient groups. So, here we go. Tonight, we're going to focus on the definition of a high-risk cardiovascular patient. We'll look at the effect of lipoprotein A on cardiovascular risk. We'll look at the role for lipoprotein apheresis in the high-risk population. What is lipoprotein apheresis? What are some of the indications for lipoprotein apheresis? And how could it be used as a treatment option in a high-risk population when standard medical therapy has been unsuccessful? I'll also point out the association of lipoprotein A on peripheral arterial disease, and certainly we'll discuss the evidence for lipoprotein apheresis as a viable treatment option for this high-risk population. So atherosclerosis exists, as I said, throughout all the vascular beds in the body, and it's characterized by chronic progressive changes modified by inflammation at the site of the lesions, and the changes are influenced not only by the presence of LDL cholesterol, but other factors such as lipoprotein A. And we've known for a long time, going back to at least 2016 in the Copenhagen study, that the higher the lipoprotein A, here measured in milligrams per deciliter, the increased incidence of myocardial infarction. So we have a direct relationship between lipoprotein A and myocardial infarction. And there's no better way to wrap your arms around the topic than with a case presentation. So we have a 60-year-old male with hypercholesterolemia, non-insulin dependent diabetes mellitus. Back in 1983, his total cholesterol is 330 milligrams per deciliter with an LDL-C of 220 milligrams per deciliter, and his mother had hypercholesterolemia. He was on multiple medications, including rosuvastatin 40, ezetimibe, icosapent ethyl, aspirin 81 milligrams, tirzepatide, metformin, and Jardiance, and he presented with chest pain and shortness of breath in 2019. He received a stent to his ostial LAD and remained with a 50% left circumflex stenosis. He was put on dual antiplatelet therapy at that time with aspirin and ticagrelor. Later in 2019, he was diagnosed with a 90% right carotid artery stenosis and underwent right carotid endarterectomy. 3 years later, in 2022, he had a 95% calcified proximal LAD lesion distal to the previous stent, and at that time he gets an additional stent. His lipid panel in 2023 demonstrated total cholesterol of 109 milligrams per deciliter, and LDL of 45 milligrams per deciliter. HDL-8, triglycerides 150 milligrams per deciliter, his ApoB was 74 milligrams per deciliter, and his LDL was quoted target with an LDL cholesterol of less than 70 milligrams per deciliter. His primary care physician and cardiologist at that time tried to get him PCSK9 therapy, but it was denied by his insurance company. In July of 2024, he has recurrent chest pain, severe 90% calcified LAD and left circumflex artery lesions, and he undergoes coronary artery bypass surgery. At that time, his LDL was 44, his total cholesterol was 103, and his HDL was 42. So this is really a case of residual risk. If you look on the right-hand side here, you see his cholesterol numbers, his LDL management. At one point, he was also on bempedoic acid until it became cost prohibitive. But you can see that his LDL, generally, again, by guidelines, less than 70 milligrams per deciliter, 54, 41, 39, 40. But what was really missing from his lipid panel? So in August of 2023, he had a lipoprotein A measured, and it was 212 nanomoles per liter. In June of 2023, lipoprotein A was measured again. It was 297 nanomoles per liter. And at that point, July of 2024, he underwent bypass surgery. So we'll talk about, this patient at the end of the presentation, but, I will point out that the fact that his LPA was elevated represented residual risk in this patient, whereas LDL was well managed. What else were we forgetting about? Other causes of inflammation, and certainly LPA would be a culprit in that area. So we know that LPA is an independent risk factor for early coronary artery disease, stroke, and aortic stenosis. Causes aortic stenosis by causing ongoing inflammation in the aortic valve area. 90% of LPA is genetically predetermined. We consider, based on the ACC-AHA guidelines in 2018, risk-enhancing feature of an LPA at a measurement of 125 nanomoles or greater, or 50 milligrams per deciliter or greater. We want to measure LPA in patients with strong family history of cardiovascular events, premature atherosclerosis, familial hypercholesterolemia patients, patients with recurrent events, premature aortic stenosis, and adults, and we'll talk about this, should they have it measured once in their lifetime. So having LP little a at a risk-enhancing level or higher represents ongoing risk for progressive disease. So, a high-risk population comes down to patients with familial hypercholesterolemia. You could pick them up very easily in your clinics. Look for patients with an LDL of 190 milligrams per deciliter or greater, patients with elevated LPA, and then you have to have some underlying atherosclerosis, either a coronary artery disease or peripheral arterial disease, and this will certainly manifest itself in a progressive state. We've known for a long time, and this work done by Domnowski, that the higher your cholesterol is in your lifetime, the earlier you will develop atherosclerotic cardiovascular disease. And on the top of the slide in the red box, there are patients with severe hypercholesterolemia from birth, and you see early onset of ASCVD. Patients with moderate hypercholesterolemia starting in their teens, again, early onset of atherosclerotic cardiovascular disease. Later in life, people with modest hypercholesterolemia from adulthood, lifestyle changes, etc., later onset. And the ones who have a low LDL cholesterol with good genetics or excellent lifestyle, they will have a lower risk of atherosclerosis. And I think that's an important point because we're all in tune to cholesterol and LDL cholesterol. But we have to remember, here we see data from the UK Biobank, and LPA, again, is an independent and direct lineage of increased cardiovascular risk. So the higher your lipoprotein A, the increased risk of a cardiovascular event. Now, in this slide, if you add patients with familial hypercholesterolemia plus an elevated lipoprotein A, then you're going to get the highest risk here up in blue. And then in orange below, you have those patients with just an elevated lipoprotein A, again, at greater risk for cardiovascular events. So having high total cholesterol and LDL cholesterol with an elevated LPA is the highest risk for cardiovascular event. And then the question is, why is LPA a problem? Well, it's a problem because it's pro-inflammatory. So you'll have increased macrophages coming into the area, sending signals over there. You have oxidized phospholipids on the surface of the LPA molecule, which are pro-inflammatory and precipitate an ongoing inflammatory reaction at that area. It is proatherogenic, so you have signaling for upregulation of adhesion molecules. You have increased smooth muscle cell proliferation. You have more foam cell formation, and then ultimately calcification of your lesions with necrotic cores. And then on the other side, it's also prothrombotic. So the plasminogen activation goes down, fibrin degradation goes down, and increased platelet responsiveness occurs. So this is like the perfect storm. So you have this molecule hitting into an area of endothelial dysfunction or endothelial disease, and then you have ongoing propagation of atherosclerosis over there. Now, peripheral arterial disease is very interesting. You know, we're pretty familiar that peripheral arterial disease is a cardiovascular risk equivalent. But patients with progressive disease on optimal medical therapy should have their lipoprotein A tested. Now, a lot of these patients are in the hands of vascular medicine or vascular surgeons that may not be too familiar with lipoprotein A, but it's important for them to make that measurement. Patients with coronary artery disease or cerebrovascular disease should also be screened for peripheral arterial disease, especially in the setting of lipoprotein A, since polyvascular disease portends a worse prognosis. So peripheral arterial disease in patients with elevated LPA and progressive disease go on to symptomatic peripheral arterial disease with limb ischemia, need for revascularizations, and they should really be considered for lipid apheresis therapy. So here we're looking at data from the 48 trial and the Pegasus trial, and they're looking at a group of patients. The 48 trial had a group of 3,600 symptomatic patients with peripheral arterial disease, and they were followed. And then the Pegasus trial was stable post-MI patients looking at the benefit of dual antiplatelet therapy in that population. But the takeaway message here is that both trials highlight the greater ischemic risk in patients with symptomatic peripheral arterial disease with and without coronary artery disease that are already on optimal medical therapy and risk factor change. So it's very important for us to understand that this is a very high-risk population, and these patients will go on and have progressive disease and ongoing events. Now, lipoprotein A in patients with peripheral arterial disease is a risk factor for future atherosclerotic events in the population. Elevated lipoprotein A in symptomatic patients with peripheral arterial disease is a risk factor for future events, and you can see the data here in a cohort of 1,500 patients followed over 3 years. 8% of the patients went on at a myocardial infarction, almost 8% of patients went on at stroke, and 4% of patients had limb amputations, and approximately 6% of patients went on and had increased death. Lipoprotein A, when it was divided into tertiles of greater than 50 milligrams per deciliter versus 30 milligrams per deciliter, you can see 1/4 of those patients with a highest tertile went on and had myocardial infarction, 2/3 had stroke, approximately 22% had lower limb amputation, and then 1/3 of these patients had any of the 3 outcomes. So even if you look at caring for patients with peripheral arterial disease and you say, okay, we revascularize the patients, you look at the data here from Tamoy and his group, that in patients with high levels of lipoprotein A of 30 milligrams per deciliter, and they were revascularized, so they underwent an intervention, You look at the major adverse cardiovascular events, major adverse limb events here, and you see that if the patients had a high LPA on the upper right there, 1/3 of those patients went on and had clinical events. So high lipoprotein A were independently associated with increased risk of major adverse cardiac events and major adverse limb events after endovascular intervention in patients that had symptomatic PAD, and it was irrespective of their LDL levels and their statin therapy. So when you have patients with peripheral arterial disease, it's important to measure the lipoprotein A because you can risk stratify a group that may not have the greatest outcomes or may have the greatest risk for subsequent events. So it portends the need for more aggressive therapy for lipoprotein A in patients with peripheral arterial disease. Now, currently, the treatment of LPA centers around lipoprotein apheresis, which is FDA-approved treatment for elevated lipoprotein A, where you can get a 70% reduction in lipoprotein A and average out about 35% reduction over time. Nicotinic acid can lower LPA up to 20-30%, but really not used for that. PCSK9 inhibitors can lower lipoprotein A about 20-30%, but again, PCSK9 inhibition is not indicated for the treatment of LPA. The other thing, which is a caveat, is that if your patient is on statin therapy, and our current approach to patients with high LPA is to aggressively lower their LDL cholesterol, LPA levels may go up 8 to 24% in patients on statin therapy. And our non-statin therapies of ezetimibe and bempedoic acid really have no significant effect on lipoprotein A. So when we do lipoprotein apheresis for our patients, it's very simple. We are using venous blood. This is not a dialysis procedure. Patients are very comfortable. At our center, we use 2 barred ports, so we're using subcutaneous central lines so the patients can have use of their arms. Other centers may use bilateral peripheral IVs. We found that the barred catheters are very effective and comforting for the patients throughout their multiple treatments. So blood is taken out. It goes through the plasma separator. Plasma passes through the absorption column where you're selectively taking out LDL, LPA, VLDL, and then the blood is warmed and then returned to the patient, and round it goes. And our procedures with our central lines take about 2.5 hours to 3 hours. As I said, the patients have use of their hands, they're very comfortable, and the procedure is, very well tolerated. Now, the other point I want to make is lipid apheresis doesn't just remove LDL and LPA, it removes a whole bunch of inflammatory markers. So we see a reduction in matrix metalloproteinases, we see a reduction in adhesion molecules, we see reduction in C-reactive protein, we see reduction in interleukin-6, we see reduction in oxidized LDL and fibrinogen. So all of these factors play a role in the added benefit of lipoprotein apheresis. So it's not just about removing the lipids, it's removing other inflammatory molecules. Now, I told you earlier that one of the things that makes the LPA a particularly deleterious molecule is the oxidized phospholipids on the surface. And you could see here in this slide in the middle section where patients had an intermediate LPA group, pre-apheresis is the top line, post-apheresis on the bottom line, and then the group in the third column is high LPA levels. But in green, in the high LPA levels, you see high levels of oxidized phospholipids, which get reduced significantly post-apheresis. So you're removing another marker of inflammation. Blood viscosity is also reduced following lipoprotein apheresis, and this work by Moriarty and his group. You could see percent reduction in blood viscosity during apheresis procedures. Now, around the corner, and then we'll see how this really, impacts everything, because again, we have lipoprotein apheresis indicated for patients with familial hypercholesterolemia. But certainly, we're all aware of the clinical trials that are ongoing, Horizon trial with pelacarsen and the Ocean 8 trial with olpasiran, where you're lowering LPA by greater than 90%. You have lipodisiran with over 94% reduction in lipoprotein A, and then there's an oral agent that can lower lipoprotein A, muvalaplin, with over 65% LPA reduction. But these agents are not ready for prime time, and we'll see, when they come out and how they can be used to help patient population. But for now, lipoprotein apheresis is indicated for the treatment of patients with elevated lipoprotein A and atherosclerosis. And we'll talk about specific indications toward the end of the presentation. But in terms of some of the data here, you can see that lipoprotein apheresis has a beneficial effect in those patients with coronary artery disease. And you can see in a group of patients with heterozygous hypercholesterolemia and coronary artery disease that lipoprotein apheresis reduced cardiovascular coronary events 72%. And here LDL was reduced 58%. And having a 70+% reduction in coronary events is certainly significant for this population. Now, the PRO-A Life study was looking to assess the efficacy of lipoprotein apheresis in high-risk patients with elevated lipoprotein A over 60 milligrams per deciliter, which would be over 130 nanomoles per liter, and with progressive cardiovascular disease. And the study evaluated the event rates for major adverse coronary events and adverse cardiac or vascular events with 5-year follow-up. And what I want you to look at on the left-hand side of the slide in red, these patients before apheresis were having ongoing clinical events. So they're waiting for lipoprotein apheresis to start, and they're having ongoing cardiovascular events. So once they were started on lipoprotein apheresis within the first year, there was a 78% reduction in major adverse cardiac events. And then in the next 5 years, there was an 81% reduction of cardiovascular events. So lipid apheresis is an effective and well-tolerated therapeutic tool, and it significantly reduced cardiovascular events in patients with elevated lipoprotein A and hyperlipoproteinemia. If we look at our data in our patients with peripheral arterial disease, we can, begin to appreciate that when you start to look at the data from the PRO-A Life trial, you saw less limb events that occurred too. So in the 170 patients they looked at, there was a significant reduction in cardiovascular events in the 2 years prior to the apheresis compared to the 2 years after lipid apheresis began. There was reduction in carotid artery and renal artery interventions and significant reductions in peripheral arterial events. So remember, Lp(a) certainly is a multiplier of cardiovascular risk in this population with peripheral arterial disease. You can even see the benefit of lipoprotein apheresis in patients with peripheral arterial disease in improving their quality of life. So they looked at a group of patients here that had elevated lipoprotein A of greater than 60 milligrams per deciliter, and compared to revascularization 1 year prior to apheresis to 2 years after apheresis treatment. You saw improvement in walking distance, you saw improvement in ankle brachial index, you saw improvement in oxygen supply, and you had improvement in their level of claudication. So lipoprotein apheresis caused a rapid and sustained improvement of peripheral arterial disease symptoms and the need for revascularizations. This slide looks at cardiovascular events over time in patients treated with lipoprotein apheresis. So what they did here is they divided the patients into groups. So the group 1 had an LPA of less than 60 milligrams per deciliter, but had an LDL cholesterol of greater than 100 milligrams per deciliter. And that's the red group. The yellow group was LPA greater than 60 with LDL-C less than 100. And then you had the third group, which was LPA greater than 60 milligrams per deciliter with LDL cholesterol greater than 100 milligrams per deciliter. And you can see again that the group with the highest events was the group that had the higher LPA and the higher LDL. The higher LPA and the LDL-C less than 100 in yellow, and the second group was just the group with the high LPA and the high LDL cholesterol. So it's important to understand that on the left-hand side, these groups were having clinical events, and once they went on lipoprotein apheresis on the right side, there was a 70+% reduction in clinical events when treated with lipoprotein apheresis. And you can see that the cardiovascular event rates after lipoprotein apheresis and the various vascular trees were certainly present in multiple territories, and they were also reduced over time. In patients with refractory angina, this is a study of 20 patients that had refractory angina and LPA greater than 50 milligrams per deciliter, and they had improvement in their myocardial perfusion reserve, improvement in their exercise capacity, anginal symptoms, and their overall improvement in quality of life. The Germans probably do the most lipoprotein apheresis in the world, and this is just looking at some of the data from their registry here, looking at major adverse clinical events being reduced here on the bottom, 80%, 70%, 78%, and you can see just above that the LPA levels going from 118 down to 33, 112 down to 36, and 87 down to 26. So effective reduction in lipoprotein A translate into a effective event reduction. So as I said, they have a large registry that was launched in 2012, looking at lipoprotein apheresis in patients with familial hypercholesterolemia, as well as those patients with elevated lipoprotein A. This is looking at the data with reduction in lipoprotein A from the registry, and you can see again the various studies in 2020 and 2022 that there's 83% reduction in major adverse cardiac events in the first 2 years compared to the pretreatment, and in the 2022 presentation, there was lower major adverse cardiac events in the group that had normal LDL cholesterol compared to high LDL-C cholesterol with background of elevated lipoprotein A. And Moriarty's group out of Kansas, again, reduction in major adverse cardiovascular events with lipoprotein apheresis. So here's some data from, again, the German registry here, and you could see, again, on the left side in orange, that patients were having ongoing clinical events before starting lipoprotein apheresis, again, in the setting of elevated lipoprotein A. So this was the group with the lipoprotein A greater than 60 milligrams per deciliter, which is greater than 120 nanomoles per liter. And you see within the first year, 83% reduction in major adverse cardiac events, including cardiovascular death, non-fatal MI, coronary artery bypass surgery, and percutaneous intervention. So the patients with the elevated lipoprotein A and so-called normal LDL cholesterol showed significant clinical benefit from lipoprotein apheresis. Again, breaking it down a little bit more here, you're looking at the various groups. Group A with isolated LDL elevation, Group B with isolated LPA elevation, and again, look at that 83% reduction in major adverse clinical events within the first year of lipoprotein apheresis. And then in Group C had elevated LDL cholesterol and elevated lipoprotein A together, and again, getting 69% reduction in clinical events. So various recommendations have come out over time in 2018 cholesterol guidelines. that we're familiar with. Lipoprotein A increases atherosclerotic cardiovascular risk, especially at higher levels with an LPA of greater than 50 milligrams per deciliter or 125 nanomoles per liter. May be considered a risk-enhancing feature, so that's what we're all familiar with. If you see those levels of lipoprotein A, it's a cardiovascular risk-enhancing feature. Dr. Soffer, who's we're fortunate to have joining us this evening, in her commentary said the most effective clinically available intervention for lipoprotein A lowering is lipoprotein apheresis. So who do we screen for lipoprotein A? As I said earlier, premature cardiovascular disease, familial hypercholesterolemia, family history of premature cardiovascular disease or elevated lipoprotein A, recurrent cardiovascular events, premature aortic valve calcification or stenosis. Should we screen everyone? Should we have universal testing? Or should we have, as well as cascade scanning for those patients? So the European Society of Cardiology came out with a consensus panel back in 2022. In the absence of specific lipoprotein A lowering therapies, early risk factor management is recommended for individuals with elevated lipoprotein A, taking into account their global cardiovascular risk. Lipoprotein apheresis can be considered in patients with very high lipoprotein A and progressive cardiovascular disease despite optimal management of risk factors. Niacin was not recommended for lipoprotein A lowering. The National Lipid Association 2024 came out with recommendations, which is a focused update to their 2019 scientific statement on lipoprotein A. They recommend measuring lipoprotein A levels at least once in every adult for cardiovascular risk stratification, and lipoprotein A levels of less than 75 nanomoles per liter or 30 milligrams per deciliter were low risk. High risk was considered those patients with LPA levels of greater than 125 nanomoles per liter or 50 milligrams per deciliter. Intermediate risk is 75 nanomoles to 125 nanomoles. Patients with elevated lipoprotein A need more intensive risk factor modification, lifestyle changes, lipid-lowering therapy to reduce their LDL cholesterol, cascade screening for first-degree relatives of patients with elevated lipoprotein A to identify other patients who may require intervention. So that's telling your patients with elevated lipoprotein A to notify their first-degree relatives, as well as their siblings, children, etc. Should all be screened. And why should we care about high lipoprotein A levels? 1 in 14 heart attacks and 1 in 7 cases of aortic valve disease can be attributed to lipoprotein A elevation. 1 in 5 individuals have high lipoprotein A and are increased risk of cardiovascular disease, and screening and therapies could prevent 1 in 3 myocardial infarctions and 1 in 2 cases of aortic valve disease in those patients with high lipoprotein A. Now, something hot off the presses, new in 2025, is FDA recommendations regarding lipoprotein apheresis. And I just want to focus in on Group D initially. So Group D, and these are the indications for treatment with lipoprotein apheresis, clinically diagnosed familial hypercholesterolemia heterozygotes with an LPA of greater than 60, greater or equal to 60 milligrams per deciliter or 130 nanomoles per liter, and either documented coronary artery disease or documented peripheral arterial disease. So clinically, hypercholesterolemia patients with LDLs greater than 190, LPA, and what they took out from this group D was a LDL level. So all you need is coronary artery disease, peripheral arterial disease, a familial hypercholesterolemia heterozygote clinical picture with elevated lipoprotein A. Group C, clinically diagnosed familial hypercholesterolemic patients, heterozygotes with LDL C greater than 70. So if your patients are not at LDL target, and either documented coronary artery disease or documented peripheral arterial disease, consideration for lipoprotein apheresis can be an opportunity for treatment with lipoprotein apheresis. So C and D are important changes for us because many patients have an elevated LPA. They have they have atherosclerosis and peripheral arterial disease or coronary artery disease, and their LDL starting out was clinically consistent with hypercholesterolemia heterozygotes, and we had trouble getting lipoprotein apheresis approved because their LDL was not at their target. So right now, Group D, no LDL target, CAD, PAD, elevated LPA, and clinically familial heterozygotes with hypercholesterolemia. So that gets back to our patient we talked about. Now, on the left-hand side of this slide is a bag of cholesterol removed from a patient through lipoprotein apheresis. And you can see also on the right-hand side, the dark yellow area that looks like a ball is concentrated cholesterol just coagulating within the bag of cholesterol. There's our machine. And then on the right-hand side, we have our data. So our patient that we have point out a few things. His LDL December 24th before treatment, because now he's getting PCSK9 inhibition, is 4, and then unable to be calculated post-treatment. But I want to point out his LPA is 101, starting out at that point on the right, and then post-apheresis, it's 38. January 25th comes back, his LDL is well managed, and his LPA is 116, and then it goes down to 32 post-treatment. So this is an every 2-week treatment protocol, but you could see within a week his LPA levels are starting to come up, and certainly this patient's had a lot of cardiovascular interventions and represents ongoing cardiovascular risk from LPA, because all throughout his LDL was less than 70, and many times it was less than 55 milligrams per deciliter. So in conclusion, high-risk patients have progressive atherosclerosis, and LDL reduction to target may not be sufficient for some patients. It's very important for us as clinicians to identify those patients that have elevated lipoprotein A and identify their residual risk related to ongoing inflammation and ongoing levels of lipoprotein A. So consider it a risk multiplier and should be part of a cardiovascular risk evaluation in patients with coronary artery disease or peripheral arterial disease, especially those patients having progressive symptoms, progressive disease. Randomized clinical studies looking at reduction in lipoprotein A, as we talked about, are underway with our small interfering RNA molecules and our ASO antisense molecules not available yet for prime time. PCSK9 may have a 20 to 30% reduction in LPA, but not indicated for treatment of LPA. Longitudinal observational studies suggest reduction of lipoprotein A by lipoprotein apheresis reduces the incidence of cardiovascular events. Peripheral arterial disease is associated with elevated lipoprotein A and forebodes a worse prognosis. Lipoprotein apheresis reduces revascularizations and improves function and symptoms in the patients with peripheral arterial disease. Lipoprotein apheresis is approved and is the most effective therapeutic intervention to reduce lipoprotein A. So I think that's an important point for us. Lipoprotein apheresis is efficacious, safe, and well tolerated, and has been shown to reduce cardiovascular events. Lipoprotein apheresis should be considered in all clinically high-risk patients with elevated lipoprotein A and either polyvascular disease or coronary artery disease or peripheral arterial disease. So I think what we've done here is give you an overview of the high-risk patients and therapeutic interventions that we have for those patients at high risk, especially those patients with lipoprotein A elevation. So I'm going to end here and take some questions, and I appreciate your attention this evening. So thank you very much.
That was terrific. Thank you very much, Dr. Mintz. This was really, really great. And we do have some questions in the Q&A, but I just want to entice people to please make this more of a conversation rather than me coming up with these questions where you and I have spoken many times over the last couple of years. So I would really love more questions from the audience. So I will wait for you to put your questions, and I'll start with some questions just to get us on the ball rolling. So you mentioned the changes to the indications, and that's huge, right? Because now you don't need an LDL level, and those individuals that have isolated high LPA can become candidates for apheresis. But there were two things that I sort of wanted some clarification on. You mentioned clinical FH. So that's also very big because that means you don't need a genetic sort of diagnosis of that. And can you speak a little bit about your clinical FH diagnosis and which are the individuals that you're mostly considering for this?
Oh, I think that's a great question. And the fact that the FDA changed the indication to take away an LDL number in the group is very important. So, you're talking about patients that may present with LDLs of initially of greater than 190, elevated lipoprotein A, um, and then and you don't need the genetic testing that we were all fighting with to get PCSK9 inhibitors improved back in the day. But uh, if you take the patient that I presented this evening, here was a patient that his LDL was always, well controlled. They held back on the PCSK9, but even at the end, he was having progressive disease due to his LPA. So here's a perfect patient who presented with, clinical FH, LDL greater than 220, and his LPA was 297. So I think, and we're getting a lot of referrals for patients with elevated LPA, coronary artery disease, or peripheral arterial disease with heterozygous FH, 190 or greater LDL.
That's great. And so for that patient, it was great that you had a patient example so people can see how it goes. When you start them on apheresis, do you change any of the other ongoing therapies? Because I'm sure you had them on multiple other therapies. Do you change that baseline therapy for LDL lowering after you see the effects of apheresis?
Yes, and I think in this particular patient who's right now, he's on a PCSK9 inhibitor, he's on ezetimibe, he's on uh, high dose statin therapy. His LDL is well controlled. You can see he's coming in with LDLs of less than 10. We're going to pull back on his ezetimibe, and what's being discussed and likely to happen is LPA rises pretty quickly after treatment in the next week, and we may move him to weekly treatment. Or FH patients, we treat biweekly.
That's great. And that was one of the questions, actually, the first question on the chat. What is the frequency? So you mentioned that you showed us monthly labs on that patient that you showed us, but that patient was having biweekly every 2 weeks?
Yeah, so he started out, and those are actually his first two lab values here. And you can see that his LPA, let me just show
Yep,
this.
we can see it.
Yeah, so his LPA is 101. And again, that's on PCSK9 therapy, high dose statin, ezetimibe. Um, and his LDLs are quite well controlled. LPA is jumping up. So this is every 2 weeks. So what we want to do with him is really treat him for about a month and see where the LPA levels go. And we know from our FH patients that they don't rise as quickly. So we can do FH every 2 weeks. And, we have FH patients with the xanthomas, corneal arcus. One of our patients had such bad xanthomas on her feet, she couldn't drive a car for 15 years. Within a year and a half of lipid apheresis, she's been able to drive first time in 15 years. So the LPA people may need to go weekly.
Okay, gotcha. Another question is checking for the lipoprotein A only helpful if there's MACE, or can it be used as screening to initiate cholesterol lowering therapy? So in whom should we measure lipoprotein little a?
Right. So I think that's a great question. The answer is, everyone. You could look at the recommendations from the National Lipid Association, which is, every adult once in a lifetime, European guidelines, once a lifetime for an adult, the ACC, AHA considering, further recommendations. So I think to get an LPA once in someone's life, it adds to the cardiovascular risk, especially in the categories of familial hypercholesterolemia, early cardiovascular disease, first-degree relatives, early aortic stenosis. But if you getting it, it's not an expensive test, and I think it, garners some important information for you in subsequent risk. And then, as I said, as a prognosticator, if you will, in patients with peripheral arterial disease or coronary artery disease, it adds to the ongoing risk. And in fact, with that particular patient I did present, while he was waiting for his apheresis to come through and he had his CABG, he actually had one of his bypass grafts also clogged. So he needed a stent even heading into apheresis.
Got it. Okay, very nice. Thank you. And so just to be clear on the guidelines, so the statements from the AHA and the NLA are statements. They're not guidelines in the US. So you did mention some individuals may not be covered unless there are secondary prevention per the ACC guidelines. But you believe that this is, it's worth the cost if it's not covered by insurance, or have you gotten LPA testing and primary prevention covered?
Yeah, I haven't seen, and thank you for the clarification. I haven't seen any pushback on measuring LPA in a while.
Okay.
A few years ago there was little pushback, but as I said, overall it's not an expensive test, and I think the value is great.
Okay. When should you measure LPA after an acute coronary syndrome event?
Well, I think, when you can certainly measure it when they come to see you for follow-up in their office. Again, this is genetically determined, and unlike some of the other biomarkers that change in the acute setting, your LPA should be pretty consistent. So I think when they come back to your office for their follow-up exam.
Got it. And then LPA is linked to stroke risk. We talked a lot about PAD and a lot about MIs and acute events, but would you say that neurologists should be on board as well?
No, absolutely. Absolutely. You can see, the way the molecule is set up, it's like a bull in a china shop, creating all kinds of inflammation, prothrombotic effects, proatherogenic effects. So whether it's in the cerebral vasculature or the coronary vasculature or peripheral arterial vasculature, it should all be measured. And when we think about stroke, especially ischemic stroke, you definitely want to look at the LPA as well. What's
Great.
the old saying? If you don't look, you won't find anything.
Absolutely. And this is a great question from Maria Ronces Durante. I forgot to write the names of the other individuals. I'm sorry, I apologize. When the targeted LPA therapies become available, do the patients need to stop having lipid apheresis?
Okay, another great question there. So, the answer is there are going to be patients with familial hypercholesterolemia that will require lipoprotein apheresis. And, I think when the various therapeutics come out for lipoprotein A, the question is, one, we know they lower LPA, but the bigger question is, do they reduce cardiovascular events, and do they reduce cardiovascular events to the degree that lipoprotein apheresis does? I showed you tonight on the slide the various inflammatory molecules and proatherogenic molecules that are removed with lipoprotein apheresis. So the LPA therapeutics are going to be just targeted at interfering with the manufacturing of LPA. So the question will be, long term, who has the greater reduction in cardiovascular events? So while I understand that there'll be patients that will come off lipoprotein apheresis when those therapeutics are available, the question is, how will they stand up next to each other with lipoprotein apheresis in terms of event reduction?
Great. So someone has a patient, I think we addressed already the primary prevention question. So Mary Abed, I hope that was a good answer for you because we addressed that question about whether to measure it in primary prevention. Eleanor Pineda has, I have a patient we're treating with low LDL in the 40s, but LPA is ranging between 150 and 230. Is it advisable to try to reduce the plasma volume treated down to 1 PV versus 1.5 PV?
Okay, I guess I missed part of the question. Is the patient undergoing lipoprotein apheresis now?
I'm assuming that is what they are considering because they're saying that they're reducing the plasma volume.
Okay. So, I mean, again, it's basically if you're talking about lipoprotein apheresis, you really want to see the levels of your lipoprotein A before and after uh, in terms of treatment. The treatment itself removes the lipoprotein A based on the positively charged molecule. So in terms of volume per se, I don't think it's going to change the result.
And so Lisa Hudgens, Dr. Hudgens has a question about what is the rebound in LPA levels between treatments like? And is there a Kroon equation equivalent to estimate the average level between treatments? Which measurement do you use to determine if the frequency of treatment is sufficient?
I think that's a great question. So, I'm not aware of any particular equation um, to predict how much the LPA is going to bounce back, but in our particular patients we see with LPA, and we have a bunch of them, they definitely bounce back over 120 nanomoles per liter within the first week and even higher. And as we map that out, we see that obviously that returns, the cardiovascular risk to the patient population. So we increase our frequency at that point to weekly, and the levels are kept pretty much below 75 nanomoles per liter, usually in the 30s.
Great. Thank you very much. Would subclinical atherosclerosis, and this is Angela Norby, would subclinical atherosclerosis be sufficient to document CAD or PAD for apheresis indication?
Well, I think that's up to the individual insurer because certainly if you have evidence for PAD, that's acceptable. And if you're talking about high coronary artery calcium scores, some insurers accept that if the calcium score is greater than 400 units. So, yeah, we've seen that in our FH population where they do have subclinical atherosclerosis, and one of them had their insurance approved for a treatment with a high calcium score.
Very nice. So I think your point is, you can definitely subclinical atherosclerosis as long as you have the other criteria, which is the LPA levels or the LDL levels. And so you showed very nicely the slide for the A through D, the indications for apheresis. So that was pretty good. And I guess the clinical diagnosis of FH. And Eleanor Pineda sort of answered us back because you were, the patient is on apheresis. And so LPA's down below 70. So I guess if, the question was, if you played around with the volumes, would that change the effectiveness of the therapy?
I don't think so, but we have an expert on the line tonight, Angela, who's the applications nurse for apheresis. So, Angela, feel free to weigh in the chat to Dr. Soffer if you think that would make a difference. I don't think we've seen it in our experience.
And so I have one interesting question, and thank you so much, everyone, for being proactive. And, no question is a bad question, so please continue to write questions in the chat. And Dr. Mintz and I will just continue to speak a little bit more about his data and things that I think may be relevant to your clinical practice. So you mentioned that when patients go on apheresis, you may try to decrease some of the, eliminate some of the ongoing therapies that they're on. Would you say that the PCSK9 inhibitors or the ezetimibe would be your first choice to go down in? And how would you test that? Like, how would you test which of the therapies would you take off first?
Okay, another great question. So the easy answer to that is the low-hanging fruit is ezetimibe. Statin therapy is very important because statins lower cholesterol numbers, but they're also anti-inflammatory. So we have a wealth of data of the pleiotropic effects of statins. So the statins need to stay on board. The PCSK9s are one dose pretty much lowers things 60%. So ezetimibe, bempedoic acid, they would be casualties to come off. And then the other question, and probably it's the art of medicine versus science of medicine versus what you want to do is, well, would you lower your statin dose a little bit based on, where you are? So I think that's a case-by-case basis. The gentleman that I presented this evening, we're going to take away his ezetimibe and reevaluate his numbers. Starting with an LDL of 4, I think we have certainly enough wiggle room
Wiggle room.
to
Okay,
take away the ezetimibe and then consider looking at his statin dosage. But as I said, it's the art of medicine is always ahead of the science of medicine. So
great.
we'll do this next year. We'll have more information on that topic for you guys.
All right, and so I have one last question before I sort of ask you more particulars about the therapy. Screening for PAD. So you kept on alluding to this where, vascular disease is a body disease, right? Once you have PAD, you can't say you don't have CAD, right? So would you, I just want you to like drive us through what would be your screening criteria and in whom would you start screening further?
Well, I think to do an ABI, ankle brachial index in the office is initiation of screening. We do that in our office on a regular basis, screening our smokers, our diabetics, and certainly picking up that group in terms of screening. And then you have your group that comes in symptomatic, and then they get screened, and then they go on for Dopplers, and then you have documentation, of their PAD. But it can start with an ABI, which primary care physicians can do in their office as well.
That's great. So finally, we're running very tight on time now, but I just wanted to, I think it's very important as we speak about apheresis and, the one therapy that we do have available that actually lowers LPA, unlike the oral therapies, which may increase it with the statins and decrease it very little with the PCSK9 and ezetimibe. What is the day-to-day of a patient with apheresis? So when they come to you, do they spend 5 hours in the center in between the therapy and when they go home? Is it how do you try to make this available and comfortable so that individuals can stick to this? Because it's not easy, right?
Right. Well, if you hang out with us, it's like party like it's 1999. So we have very comfortable room for the patients using the barred ports. So we're using central lines, subcutaneous central lines. We can get the patients treated in, as I said, 2.5 hours, 2 hours and 45 minutes. If you're using peripheral RVs, it takes much longer. So the patients are sitting in very comfortable chairs. They can be on their iPads. They're doing their work on their computers or on their cell phones. We have our, 2 nurses with them, at all times, our ICU nurses. We introduce them to the room when they're considering joining our apheresis therapeutic team. And as I said, this is not like dialysis where they get up exhausted. It's very well tolerated. And they're able to, drive home and snack. And as I said, very comfortable. And if anyone is really interested in the greater New York area and you want to see it, reach out to me and you can see it on a Thursday.
Very nice. So this has been an amazing session. Thank you very much. Very informational. There are only 2 centers in New York State, and you run one of those centers, and I think you're the most active center probably right now. But Dr. Lisa Hudgens was also on this call, mostly PED individuals at Cornell. But I think this has been a great seminar, and if obviously, as Dr. Mintz said, reach out if you're interested. And thank you very much, and have a wonderful night. 8 o'clock on the dot.
Thank you very much.
Have a good evening. Thank you so much, everyone.